We'll be presenting the findings of research conducted by All.Can Canada entitled Optimizing Entry into Canadian Cancer Care Systems. My name is Leah Stephenson. I'm a Canadian woman of Eurasian ancestry with curly brown hair and brown eyes. I'm the strategic lead at All.Can Canada.
And my name's Villalba. I'm a Canadian of Southern European ancestry with glasses, straight brown shoulder-length hair, and brown eyes. I'm the executive director of the Quebec Cancer Coalition and a member of the All.Can Steering Committee.
Having consulted with representatives across the oncology ecosystem, including patients and patient group representatives, All.Can Canada commissioned research to understand the current state of cancer diagnosis across the country, with a focus on ensuring swift, accurate, and appropriately delivered diagnosis. As a first step, it was decided that a rigorous scan was needed to identify outcomes that matter most to patients, review promising practices in cancer diagnosis, and explore areas of inefficiency that represent opportunities for improvement. The research was conducted from June 2020 to March 2021 by an independent third-party consultant with strategic oversight and guidance by All.Can Canada's multi-stakeholder, patient-led interim steering committee. The scan included a literature review, 30 qualitative interviews with cancer survivors across Canada, and a survey of relevant healthcare providers across the country. Irrespective of cancer type, stage of disease, or social determinants of health, patients with lived experience describe the diagnosis process as taking place in 3 distinct phases. In the early phase, it's the period from when a person first tries to contact or interact with a healthcare provider over a suspicion of cancer until the first referral to a diagnostic facility for testing. The middle phase is the period during which a person undergoes diagnostic testing to investigate a suspicion of cancer. And the final phase is the period from when a person arrives at a dedicated cancer facility to the time they receive their cancer diagnosis. We found that satisfaction with the diagnosis experience differed markedly by phase, with most people finding the early and middle phases to be the most challenging and the final phase to be quite a bit smoother. Across all phases of the diagnosis journey, 7 outcomes were voiced by people as being critical to the diagnosis experience. 1, swiftness of the diagnosis process. 2, validation of concerns by primary care providers. 3, excellent patient-provider communication. 4, effective provider-to-provider communication. 5, better information. 6, integrated psychosocial support. And 7, coordinated and managed care. Our characterization of the current state of diagnosis in Canada is bleak and has been described by many as the most challenging period in the entire experience. People continually face challenges in the early phase of diagnosis as they try to have their concerns validated and appropriately investigated. Perhaps the best word to characterize the current state of the middle phase of cancer diagnosis is overwhelming. Time and again, people in our study used this word when describing the multiple facilities and providers they were forced to navigate on their own. What mattered most to people throughout their diagnosis journey was oftentimes the opposite of what actually happened. This map offers a snapshot of what the current diagnosis journey looks like for people in Canada who are investigating a suspicion of cancer. One thing is clear, we have a lot of work to do to achieve the 7 outcomes which people identified as being the most important for a quality diagnosis process. Achieving an improved future state of cancer diagnosis doesn't mean we have to start from scratch. Through our research, we learned about numerous opportunities and existing practices that, if adapted and scaled for jurisdictional and regional needs, can be an excellent place to begin the realization of an optimized future state of cancer diagnosis, in which the 7 key outcomes are achieved for everyone. This slide offers a snapshot of what the diagnosis journey should look like for people in Canada who are investigating a suspicion of cancer.
Now we'll dive into issues, opportunities, and spotlight practices for each outcome. The first is the swiftness of the diagnosis experience. As people cycle among primary care providers, allied health professionals, and emergency rooms in the early phase of diagnosis, delays of months or years occur as people seek validation of their symptoms and subsequent referrals. Delays are further compounded by unnecessary rework due to referrals which fall through the cracks. During the middle phase of diagnosis, waiting is the norm, waiting for an appointment, waiting in waiting rooms, and waiting for test results. Waiting to find out what test results revealed was one of the most stressful parts of the cancer journey. Rapid referral pathways for diagnostic testing upon presentation of symptoms to a primary care provider expedites early diagnosis. Diagnostic centers, labs, and technologies are in a position to fast-track early diagnosis if services are available and if providers within these facilities move quickly to interpret and communicate test results. One spotlight practice we'd like to flag for you is telepathology, which uses telecommunications technology like high-definition scans to facilitate the transfer of pathology data between distant locations for the purposes of diagnosis and research. Telepathology eliminates the needs for patient travel to access care while helping pathologists to do their job faster and more accurately. Validation of a patient's concern by primary care providers, allied health professionals, and ER physicians is a critical first step towards initiating the diagnosis process. The early phase of diagnosis for many is characterized by cycling through multiple and repeat visits to primary care providers for months or years as symptoms are dismissed or misdiagnosed. People reported that their physician tended to minimize or dismiss their symptoms, leaving them without answers, or even in some cases, an inaccurate diagnosis accompanied by inappropriate medication prescribing. Optimizing the role of primary care providers is accomplished through supports to help them arrive at risk-informed decisions, such as electronic cancer clinical decision support and risk assessment tools. Enhanced provider education about cancer types, symptoms, and diagnostic pathways is an opportunity. Standardized care pathways are management tools for patient care during specific phase of the cancer journey. They facilitate mutual decision-making and organization of care for cancer patients. At the time of communication of the cancer diagnosis, what mattered most to patients was that the news was communicated in a compassionate and caring manner, that they were given the opportunity to ask questions and get answers, and that the next steps were explained. Sadly, these needs are not always met, and people are often left feeling afraid and in the dark. Fortunately, excellent communication skills can be learned through training or guides. Whether the encounter occurs in person, virtually, or over the telephone, compassionately telling the patient what the next steps will be and asking if they have any questions before ending the conversation are critical to excellent communication. Online portals that give patients access to health information can support shared decision-making between patients and providers. As an example, Nova Scotia has developed a pre-diagnostic resource for providers. It's unique in that it's dedicated specifically to the diagnosis phase of care and includes not only an initial presentation algorithm, but also guidelines for enhancing the patient experience, including a set of provider-patient communication guidelines. The Nova Scotia Health Authority has developed the Serious Illness Conversation Guide, which consists of a set of resources and tools designed to trigger conversations about serious illness. The negative repercussions for patient care arising from poor provider-to-provider communication include missing or overlooked test results leading to repeat testing, lack of awareness of history leading to inappropriate or repeat testing, misdiagnosis, conflicting opinions, conflicting information, canceled tests, confusion for the patient about next steps, distrust in providers and the system, lack of timely follow-up, and delayed diagnosis. Health information systems, including interoperable electronic medical records that facilitate the secure sharing of a patient health information between providers working with a common patient, no matter where they work, is an opportunity. In the current state, information was sometimes given all at once, resulting in information overload, or was not appropriate for the individual in terms of personality or their learning style. Oftentimes, people were left to their own devices to get the information they needed. Throughout the diagnosis process, information needs vary depending on the stage of diagnostic process that the person is in. When a person is first referred for testing, the information is needed about what the diagnosis pathway entails for their specific type of suspected cancer. The information should be just enough that the person understands the entire pathway, but not so much that it becomes overwhelming. As people undergo multiple diagnostic tests and procedures, information about each step is needed and should be given before that step occurs, so that the person has time to prepare for it and knows what to expect from that test and whether more tests may be needed to ask questions and have their questions answered. When the final diagnosis is communicated, people need information about aggressiveness, size, and staging, and about treatment next steps. They need to know who to contact if and when they have questions. For those not yet diagnosed, but who are undergoing investigation, a psychosocial support network is needed. Currently, a psychosocial support network is largely non-existent for people undergoing investigation for cancer, and we found no evidence of any type of psychosocial support being proactively integrated into the diagnostic process. The majority of people in our study found themselves unable to access services in a timely manner, being put on wait lists of up to 6 months after their diagnosis, which did them no good after the fact. Today, there is a scattering of psychosocial support programs and services available to cancer patients nationally, provincially, regionally, and locally, some specific to cancer type and some with a different focus. But there's still none that are specific to this stage. The lack of integrated psychosocial support for people in this phase represents a significant gap, especially that we know that treating the whole person goes a long way to treating the actual cancer. The absence of a care coordinator was understood by both patients and providers to be a significant gap in the diagnosis phase of cancer care. While both providers and patients alike try to rely on the family physician to act as a touchstone throughout the diagnostic process, the success of this depends very much on the pre-existing relationship with the physician and the patient. For people living in rural and remote areas of Canada, travel to diagnostic facilities was unavoidable at some point during the diagnosis process due to a lack of local specialized testing facilities, scantness of providers, and/or overcrowding of facilities due to the COVID-19 pandemic. Financial and logistical support for patients living in rural and remote areas of Canada who travel regularly for investigation are lacking and must be provided to ensure equitable access. Care coordination, multidisciplinary teams, diagnostic assessment programs that bring together teams with care coordination and single facilities for diagnoses are opportunities to create more integrated cancer care during diagnosis.
Measuring the quality of the cancer diagnosis experience will tell us if our efforts are making a difference. Using shared and sound measures will help us to make comparisons and improve across settings and jurisdictions. Indicators which can be used to measure the patient experience, commonly referred to as PREMs, are suggested in this table and are aligned with each of the 7 desired outcomes identified through this research. The measures in the table are common to all cancer types, stage of disease, and social determinants of health, and can therefore be used to benchmark and compare the patient experience across cancer populations and jurisdictions. While this indicator table is a cursory start, it represents the beginnings of a quality framework for cancer diagnosis in Canada, much like those which have been developed for the post-diagnosis phase of cancer care. Once this framework is fleshed out, tools can be developed to measure patient experiences and outcomes in the diagnosis phase, much like those which measure PROMs and PREMs in the post-diagnosis phase. Finally, here is a set of 5 recommendations aimed at policymakers and those working in cancer control to improve the swiftness, accuracy, and appropriateness of communication of a diagnosis in Canada. This research represents an important step in understanding the current state of patient entry into Canada's cancer care systems. The research adds to the limited body of knowledge about inefficiencies and opportunities within the current systems of cancer diagnosis in this country. Examined together, the findings are encouraging. We're not starting from scratch, but there is much work to be done. The recommendations contained within this report serve to improve the diagnosis phase of the cancer care system, such that it can not only absorb shock, but also improve. Thank you so much.